Hello, and welcome to this edition of Doc Talks. I'm Dr. Don Selvey, a naturopathic physician practicing in Chandler, Arizona. In this version of Doc Talks, we're going to focus on vitamin B12. A medical disclaimer that's necessary. We are only going to provide information for educational purposes here. Nothing should be construed or intended for medical advice, diagnosis, or treatment. Do not use this in place of advice of your own physician. If you'd like to make an appointment, we'll give you that information at the end of this presentation. As we continue our discussion on Doc Talks of depression, we're now going to move into a discussion of the pharmacologic treatment of depression. There's an incredibly important caveat that we need to give here. Very important for patients and caregivers, anyone to know that when a dose of a antidepressant medication is initiated or is changed, there is a risk of patients who have depression feeling more angry or anxious or even more depressed, particularly in that first week. Some patients, especially children and adolescents, may become increasingly suicidal. That is, they may have ideas of committing suicide ideation. So close and careful monitoring is absolutely essential. To understand the treatment pharmacologically of depression, it's going to be really necessary to understand some of the chemistry of the brain when it comes to depression. This can be a little bit technical, I'm sorry, but we'll try to make it make sense to everybody. In the body's nervous system, we're having electrical signals that are conveyed from nerve to nerve. Between the nerves is a synapse or a gap. And in order for that electrical signal to go from neuron to neuron, nerve to nerve, across the synaptic cleft, we use a chemical that's called a neurotransmitter. So the signal is going to go electrical signal to chemical signal to electrical signal. We want to focus just a little bit on those neurotransmitters. So this very generalized explanation is important to understand this. We have the electrical signal converted to a chemical signal. It crosses the synapse, and then the signal is going to be converted back to an electrical signal in the connecting neuron and continue on its path. We're going to focus on the chemical neurotransmitters. The first of these is serotonin. Chemically, it's called 5-HT, but we all know it as serotonin. We have here a representation of a synapse. So the top part is going to be a neuron. It's actually the axon of the originating neuron, and then below that is going to be the next neuron. Can be a dendrite or a nerve cell body, doesn't really matter, but it's the connecting neuron. And I want you to look at this, but pay attention to three things. One is the little part of it that's called the synaptic vesicle, or here it's just the vesicle. This contains the serotonin. I want you to see also the serotonin that is in the gap. And then thirdly, the receptors for serotonin on the adjoining neuron. So it's synaptic vesicle with the serotonin, and then the receptors for the serotonin. Unless the serotonin finds the receptor on what we refer to as the postsynaptic membrane, the signal cannot be continued. So it isn't just that the serotonin has to be released from the synaptic vesicle and that it has to flood across, it must find the correct receptor on the postsynaptic membrane. Now, once the serotonin signals the receptor, a different mechanism occurs, and it's not depicted here in this diagram. A different mechanism goes into work to remove serotonin from the gap and return it to the first neuron. It's a form of recycling at its very best. So the serotonin is going to be taken back up into that originating nerve cell. So key word here, the process of recycling the neurotransmitter is called reuptake. And so very specifically in these types of neurons, we're talking about serotonin reuptake. When there is inadequate serotonin or 5-HT in the brain, that is most frequently associated with the condition people recognize as depression. So while there might be other factors that go with depression that we've talked about in the previous presentation, this lack of serotonin is a key element to depression. I'm sure you're following along so far, but we're going to make it just a little bit more complicated now. We're going to explain that there are at least three types of receptors on that postsynaptic membrane. We call them, curiously, 5-HT1, 5-HT2, and 5-HT3. Three different receptors on that membrane. Of those three receptors for serotonin, the 5-HT receptors, number one reduces depression and anxiety. So when there is adequate serotonin on the receptor that we identify as 5-HT1, a patient is not going to be depressed and they're going to have a little bit less anxiety. Unfortunately, 5-HT2 and 5-HT3 are opposites. So when there is adequate serotonin on the receptors that is going to reduce depression, having that much serotonin can induce anxiety, can induce insomnia, will induce sexual dysfunctions, particularly decreased libido and erectile dysfunction in men. 5-HT3 is associated with nausea and headache. And again, if there's too much serotonin, the patients are going to have nausea and headache. I think what you can see right now is we're going to talk about some of the side effects of some of these serotonin reuptake inhibitors. This is a nice lead into our discussion about the various drugs. So as you can imagine, most antidepressant medication will work to alter serotonin levels in the brain, specifically trying to increase the serotonin levels on that postsynaptic membrane. So the first category of drugs that we will talk about is what's known as a selective serotonin reuptake inhibitor, or an SSRI. The most common SSRIs are listed here: citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, and vilazodone. These are very common SSRIs. There are other SSRIs, but these are going to try to work to inhibit reuptake of serotonin. Therefore, more serotonin will be on that postsynaptic membrane. It said the function of the SSRI is to inhibit reuptake, leaving serotonin to stimulate that postsynaptic membrane. Having said that, that's the purpose of an SSRI. Let's go back to the slide we looked at just a minute or two. There are three different types of 5-HT receptors. So if we are going to reduce depression, do you see that a risk of a side effect here is that we might induce anxiety, induce insomnia, induce sexual dysfunction, including decreasing libido and inducing erectile dysfunction. We might induce nausea, we might induce a headache. So prescribing an SSRI and a patient taking an SSRI is a real balancing act. We have to make sure that we are not being careless in how we prescribe an SSRI. And patients, you have to be very careful in how you take your SSRI. You might get rid of your depression, but have insomnia, nausea, headache, etc. In addition, the SSRIs are known to cause weight gain, to cause diarrhea. Some of them will interact with other drugs, particularly drugs that are classed as beta blockers. Beta blockers are used sometimes in as an antihypertensive and for other cardiac situations. And you can recognize them pretty easily. They all end in OLOL. So metoprolol, atenolol, propranolol, etc. Those are beta blockers. And the SSRIs will interact. The next category that we want to talk about are known as serotonin modulators. They are not inhibitors, they're modulators. So these block 5-HT2 receptors, but apparently without the normal sexual side effects that we see with SSRIs. So two of the biggies there are trazodone and mirtazapine. Trazodone is very sedating, so it's very commonly used to treat insomnia. And I will tell you that the guidance is never, 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 never take trazodone for more than 5 consecutive days. You can have a problem with that. So while it does help with insomnia, it's not the best possible choice. The next category are SNRIs. These are drugs that are going to inhibit the reuptake of serotonin, but also the reuptake of norepinephrine. And here's a couple of the names of them: desvenlafaxine, duloxetine, levomilnaprsan, venlafaxine. I can't even pronounce that last one. There are a number of these SNRIs. At this point, it's perfectly appropriate for you to say, what the heck is a norepinephrine? This is the precursor to epinephrine, which is what is sometimes called adrenaline. The real name is epinephrine, but norepinephrine produces epinephrine. Inadequate norepinephrine will cause a feeling of very low energy. Some of my patients have described it as feeling like a zombie. So if you have low norepinephrine and then you have low epinephrine, this is the drug, this is what is going to be responsible for in your body, the neurotransmitter that is responsible for the so-called fight or flight response. When you are startled, when you are frightened, when you have something that you have to deal with on a fight or flight basis, that relies on adrenaline, which relies on norepinephrine, which is blocked by the SNRI drugs. That's the reason that some patients feel like they are a zombie. They don't care. I'll give you a classic example of a patient who is a realtor who is on an SNRI drug. You may or may not know that when a realtor gets a contract, they have to deliver that contract for consideration immediately. And this realtor just decided she didn't need to do that because she didn't have any sense of urgency, because she was on an SNRI drug. SNRI drugs will make you not feel like you have any sense of urgency. If your child is sick, you might say, I'll deal with that tomorrow. If you're driving your car and somebody runs out in front of you, I don't know that I'm going to hit the brakes. That's a bit of an extreme example, but the SNRIs have a really serious impact. Be very careful about the SNRI drugs. The next drug that we want to talk about is not part of the 5-HT system. This is bupropion. It is typically used in persons who have ADHD or they are addicted to cocaine because this drug apparently blocks that receptors, but we use it more for helping people to stop smoking. The risk of bupropion is seizure at high doses. The good news is there are no recognized sexual adverse effects, but it's typically used more for helping people to stop smoking than it is for anything else. So the next category are heterocyclic antidepressants: amitriptyline, nortriptyline, imipramine, desipramine. We don't use these very much. There's a high degree of toxicity, high rate of side effects, including seizures. This is absolutely an unsuitable medication for an older patient, particularly one with glaucoma, someone with chronic constipation, or men with benign prostatic hyperplasia. Don't use these heterocyclic antidepressants. Bad choice. The last resort drugs, when everything else fails, are known as monoamine oxidase inhibitors. Monoamine oxidase is an enzyme that breaks down serotonin and dopamine and norepinephrine. The big issue with a monoamine oxidase inhibitor is what's known as the cheese reaction. Foods that are high in tyramine or in dopamine can cause a hypertensive reaction. To prevent these adverse effects, patients who are taking the MOAIs must absolutely avoid certain foods: malted beers, Chianti wine, sherry, cheese, pickled herring, caviar, liver, soy sauce, sour cream, yogurt, etc., because these are going to induce a side effect because of their reaction to tyramine. The final category is the ketamine and esketamine drugs. So this drug used to be an anesthetic for general anesthesia, and it produces a hallucination, which is a form of a neuroplasticity reaction. And people have nightmares for a long time afterwards. And so they would have the surgery with the ketamine as a general anesthetic, and then they would have a nightmare type of reaction. Well, it turns out that if it is injected as an IV in very low doses, it can produce a rapid, short-lived relief from depression. However, when we say it's rapid and short-lived, pay attention to this. It peaks in 3 to 4 hours, it wanes over 1 to 2 weeks, and then you have to do it again. Side effects are nausea, vomiting, hypertension. These patients must be given this drug in a clinic by IV. They have to be monitored for a minimum of 2 hours after the administration of the medication, and then they are not allowed to drive for at least the next day. As I wrap up this part of our discussion on depression, I want to ask a couple of questions. Considering the side effects of the common antidepressants, not to mention the high costs of these antidepressants, is it any wonder that so many people are looking for an alternative? And wouldn't it be great if there was an effective, painless, fast, easy way to help people who have depression? You have to know there is, or I wouldn't have asked the question. This is Dr. Don Selby. Thanks for watching.